A very good morning. So the topic for today's lecture is vital pulp therapy. In this we'll be covering the introduction, the vital pulp therapy, what it is, the concept, the direct and the indirect pulp capping, what is the proposed protocol for the treatment, the conclusion. So when we talk about the vital pulp therapy, so that means we are talking about the pulp which is vital. We are doing a treatment of a vital pulp. Vital pulp therapy is the treatment initiated on an exposed pulp to repair and maintain the pulp vitality. The idea behind is that for any reason, for that matter, it could be trauma, it could be caries, the pulp has become exposed or it is at the verge of exposure. So in that case, if we feel that the pulp, it's not about that we feel, it is about the clinical symptoms, the radiographic picture. If we have identified that yes, the pulp is still in a position that it can be maintained, it can still maintain its vitality, so these procedures are undertaken. So aim is to treat the reversible pulpal injuries in order to maintain the pulp vitality in both the primary and the permanent tooth. So this can be done in both the dentitions, and the important word is reversible pulpal injuries, that after examining it clinically and radiographically, we have found that the pulp is still in a reversible state. So we can take up the procedure. What will happen if you maintain the vitality? It will preserve the immune defense mechanism, because any tooth, for that matter, pulp is the only place from where it gets all the immunity. So if we have maintained the vitality, we are maintaining the immune defense mechanism and the regenerative potential. For example, there is a trauma which is occurring to a tooth which is still immature, that is, the root formation is not complete. And in that state, if the trauma occurs and the pulp becomes necrosis, so that tooth cannot regenerate, the full formation of the root will never occur. So if we want that the complete formation of the root occurs in that tooth, we have to maintain the pulp vitality. And also, the vital tooth has a structural integrity, so it will be more structurally integrated in the oral cavity. Now the indications: the immature permanent tooth, like the reversible pulpitis caused by the mechanical pulp exposure during the carious excavation or operative procedure. As I mentioned, it could be due to caries, it could be due to trauma, or it could be due to iatrogenic errors, that the pulp has become exposed or it is on the verge of exposure. So in all those cases, we can go ahead with the vital pulp procedures. That means the most important thing is that we have to identify the pulp is still in a reversible, it is a reversible pulpal injury, or the pulp still has the capacity to heal. Only in those cases we take up these vital procedures. The mature teeth, as I just gave you an example, the traumatic pulp exposure of a healthy tooth with minimal bacterial contamination. When a trauma occurs and if that trauma is taken care immediately, that means the bacterial contamination is still under control and we can achieve or we can maintain the vitality of that pulp. Now the procedures which are done are indirect pulp capping, the direct pulp capping, and the pulpotomy. So when we talk about the indirect pulp capping, as the name suggests, indirect pulp capping, that means the pulp is still not exposed and we are covering it. Capping it, covering the pulp. So this is a procedure where the deepest layer of the remaining affected carious dentine is covered with a layer of a biocompatible material in order to prevent the pulpal exposure and the further trauma to the pulp. So here the two important point is the remaining affected carious dentine, that is, we still have a dentine over the pulp which is affected, not infected. The difference we'll be seeing in the further slides. And we are placing a biocompatible material. So what is the role of this biocompatible material here? That this biocompatible material will initiate or will stimulate the underlying dentine to produce the tertiary dentine. So we have to specifically see the indications. It is indicated in large carious lesion without any frank pulp exposure. The indirect pulp capping, that means there is no pulp exposure yet occurred. But apart from this large carious lesion, that is a clinical picture, we have to see the radiographic picture also. That means there should not be any radiographic changes. The surrounding lamina dura should be intact, no periapical changes. So radiographic picture has to be evaluated along with, and there should not be any history of spontaneous pain, pus discharge. All these things should be absent. and the normal response to the thermal testing. That is, the tooth should be responsive or should show a positive response to all these electric pulp testing or the thermal testing. Now, as I mentioned, that there is a difference between the infected and the affected dentine. Infected dentine, which is a superficial layer which is contaminated with the bacteria, which is not possible to remineralize. It has denatured collagen. And while the affected dentine, which is still a deeper layer, it has intact collagen. It has the capacity to remineralize. So that can be left, and the infected has to be removed. So what is the approach, how we go about the indirect pulp capping? There could be 2 appointment or the 1 appointment. In the 2 appointment technique, first what we have to do, we have to provide the anesthesia, the rubber dam isolation, and then we remove the caries. While removing the caries, we are removing the infected, leaving the affected. And once we see that there is no pulp exposure and no signs of irreversible pulpitis, so we place or we cover that remaining affected dentine with the calcium hydroxide, and then we are placing a intermediate restorative material. That is a temporary material we are placing. And in the second appointment, which is generally after 3 to 8 weeks, because that is the time which is required for the dentine to form a dentine bridge. And when we realize that the patient is completely asymptomatic and the radiographic and clinical pictures is absolutely normal, then we again provide the anesthesia, isolation, and the temporary filling which we have placed is removed, and it can be clinically evaluated for the dentine bridge. And then if we feel that, if we find that everything is okay, then we place another layer of calcium hydroxide and a permanent restoration of your choice can be placed. So in 1 appointment technique, the second appointment is done in the first step itself. That means we have removed the carious lesion, we have placed a biocompatible material like a calcium hydroxide, and over that we are placing a permanent restoration in the first sitting itself. So this is how it is different. It has both has its own advantages and disadvantages that we'll discuss later. Then direct pulp capping. So this is a procedure in which the exposed vital pulp is covered with a protective dressing or base which is placed directly over the site of exposure. In the previous, we are still having a layer of a dentine. Here there is a direct exposure, but since in the cases like a trauma, where as I mentioned the bacterial contamination is minimal, or by chance the iatrogenic error has occurred while preparing a cavity, you have exposed a pulp. So in all these cases it can be taken up. So the criteria or the indications are there should be a small exposure which is less than 0.5 millimeters. Exposure is clean and uncontaminated. No spontaneous pain, normal response to thermal testing. So all these criteria have to be checked while going for the direct pulp capping procedure. Here the procedure will, and the important step is hemostasis has to be achieved, because since it's a pulp, it will bleed. So if you are able to achieve the hemostasis, that means the bleeding can be controlled, which can be controlled with using the sodium hypochlorite. Once the bleeding is controlled, then we place a calcium hydroxide and the material of your choice. It could be composite amalgam or any restorative material of your choice. And nowadays, instead of calcium hydroxide, we are going for other bioceramic materials like the MTA or biodentine, because these materials are giving good response while they are being used for these procedures. Another procedure is the pulpotomy. This is a procedure in which a portion of the exposed coronal vital pulp is surgically removed as a means of preserving the vitality and function of the remaining radicular portion. So it is important to maintain the vitality of the radicular portion, and we are removing the coronal pulp. This is mainly done in the immature permanent tooth, where the root formation is still incomplete and we want to achieve the formation of the root. So the pulp exposure in permanent tooth with incomplete root formation, 3 to 4 mm of apical pulp is still vital. So we feel the apical pulp is still vital, so we are using this procedure. So these are basically 2 types, the civic pulpotomy or the partial, where only the infected portion or the half of it pulp is removed, coronal pulp is removed, and the cervical, where the complete coronal pulp is removed and the radicular pulp is left. And the idea, as I mentioned earlier also, that the idea behind this vital pulp therapy procedure is that it initiates the formation of a reactionary dentinogenesis or the reparative dentinogenesis. This is occurring beneath that material what we are placing. So basically, when we are placing that biocompatible material, it is initiating the formation of the dentine bridge by stimulating the underlying odontoblasts. The odontoblasts are being stimulated and then they form the tertiary dentine, which is known as a dentine bridge. Thank you.